Hello and welcome to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor at JAMA Network Open. Of course, if you're following along live, send us your questions or comments on Twitter at JAMA Network Open or Facebook or YouTube Live in the comment box by the video. Today, we are talking about the assessment of disparities in COVID-19 testing and infection across language groups in Seattle, Washington. We've got first and last authors of the study, Drs. Nina Kim and Dr. Herbie Duber. Welcome.
Hello.
Thank you.
Thanks. Nina and Herbie, if you could start off, just tell us a bit about who you are, what kind of work you do, and why you did this study.
Sure. I'll start by introducing myself. My name is Nina Kim. I'm an associate professor of medicine in the Division of Allergy and Infectious Disease. I'm an ID specialist, and I work at Harborview Medical Center, which is the main public safety net hospital here in Seattle. Herbie, I'll let you introduce yourself.
Sure. Thanks, Nina. Thanks, Seth. So my name's Herbie Duber, associate professor and section head of population health in the Department of Emergency Medicine at the University of Washington. And I'm also faculty at the Institute for Health Metrics and Evaluation, or IHME. I also work at Harborview, and I think that a lot of what drove us to do this work is the mission of Harborview, which is really focused on underserved and vulnerable populations, specifically immigrant populations in the Seattle area.
Okay. Interesting. This is great. I mean, I think there's been a lot of discussion overall about which vulnerable groups have been hit hardest by COVID-19, especially looking at kind of the broad census categories like Black people, people of Hispanic origin, et cetera. But you guys did an interesting look and looked at language spoken and non-English speakers. So tell us what you did here in the study.
Yeah, so we were interested in this because even within that first month of our local epidemic, after we were seeing a lot of the elderly and nursing home affiliated patients coming in, the other thing that really struck all of us who were down in the emergency room, like Herbie or myself in the wards, was that a lot of the people we're admitting were Spanish speaking, so Latinx origin. And then when you looked broadly at our public health data and our UW medicine data, it was a lot of Latinx, Pacific Islanders, limited English proficiency communities were being hit, and the ones who were coming into the hospital. So we were really interested in looking specifically at language groups. And so what we looked at, all of the living patients who had interacted with us at least once, so at least one visit or phone visit of some kind, from January 2019 to February 28th, 2020, we started putting testing online around February 29th. That was really the start of the epidemic for us. And we looked at the first 3 months of the epidemic, and looked both at testing rates as well as test positivity rates, so both testing and infection. And so we were looking at a denominator of just north of 560,000. Of these, 5.5% underwent testing. 6% didn't speak English. And what we noted was that non-English speakers were a little less likely than English speakers to get tested, 4.7% compared to 5.6%. You can see that on figure 1 of our study. There was a fair amount of heterogeneity when you looked at that, but there was a trend to less testing. But I think one of the most striking findings was that the proportion of positive cases was 4.6-fold higher in non-English speakers when you looked at it in pooled way. 8.6% was the positivity rate compared with English speakers, which was 4%. And this excess risk was observed across the language groups. It was really quite striking, and included our 3 largest, most populous non-English language groups, which were Spanish, Vietnamese, and Amharic.
Yeah, really interesting. And one of the things I really like about what you did here in the study is, and as we've all kind of become experts in testing and test access over the last few months, you're looking at both who's getting tested as well as test positivity, not just raw numbers, which I think we all understand is kind of a bit of almost like a biopsy of how hard the community is hit. And the test positivity being higher kind of washes out. It's probably an issue of test access or access to care in some of the vulnerable populations. Can you speak to that at all?
Yeah, I mean, I think the testing rate is kind of interesting because our denominator was that we required them to actually had at least one contact with us. But the truth of the matter is many members of these communities may not have actually even accessed healthcare or had a like clinic they could identify to go to for testing. So I think it's really not getting at the whole heart of this maybe disparities around access. So that's something you have to, interpret with a grain of salt. But yes, I think it was. I mean, it was very clear that this is a group that they're going to have trouble sort of accessing, and we noticed these disparities early on. The UW Medicine leadership, and they made an effort to try to bridge these gaps. Deployed mobile units, testing vans to these different neighborhoods. It was a big concerted outreach effort through these different neighborhoods, and it was sort of a cross-sector collaboration with these communities. And Herbie, if you want to.
I think it's worth pointing out that this, especially early on in the pandemic here in Seattle, this was patient-initiated testing. So this was symptom-based. And I think that for many immigrant communities, it may be more difficult to kind of express some of those symptoms, particularly when you think about limited English language proficiency, and health literacy. So when you go to a provider, are you able to adequately communicate those signs and symptoms associated with COVID illness? And so you do wonder to what extent this is because providers may not have kind of clued into those things, and therefore testing may be a little bit lower in these communities, or people just weren't seeking care and we weren't getting out to these communities sufficiently enough.
Yeah, and when I see a test positivity rate, exceeding 20% and a testing rate that's like around 5%, I think, man, how many cases are we actually missing? And so that, I think our findings also, that's kind of the elephant in the room as well. Right. Is, maybe we needed to have done way more testing, and yet we didn't have the capacity to. I mean, I remember a Como 4 news story coming out where, they had just deployed these vans and there were cars kind of around the block, lining the block. So there was clear demand, but it was a big effort. I mean, they had to create appointment phone lines that in each of the different languages in order to allow people to be able to access and set these times up. I mean, they did walk in on the spot testing, but really it was people were encouraged to pick a time. But yeah, no, it took a lot of effort.
Yeah, it's hard. I mean, even now where Chicago, the numbers are relatively, I think, functional, or allows us to be functional, it's still really hard to get outpatient testing, especially rapid testing. We're still seeing a lot of testing in emergency departments. When I have, friends reach out and try to figure out how they can get testing here, it's still a huge hassle. It's hard to find. Most of the places that are offering testing are pretty filled up. And now I think one of the things you address well in the study here is, the non-English speaking immigrant populations, which have, all sorts of other reasons why it's hard to access care. People with jobs that are hard to or impossible to telecommute from. People who, essential workers working in food service, healthcare, poor access to care in general, difficult public health communications, as you talked about, and then concerns about things like stigma and deportation, which we've seen not just in this pandemic, but historically back. I mean, I remember in my MPH program, learning about the yellow fever pandemic in 1900 and the kind of xenophobia that happened then, and we're seeing waves that were, I don't know, different aspects of that again here now.
Yeah, I think it's really unfortunate that current debates around immigration have really force people to think about accessing healthcare in a really different way that it shouldn't be part of the discussion, right? If you need healthcare, you should be able to access healthcare. And unfortunately, I think current discussions kind of push people away from that. There is fear about entering a system, even though it is a healthcare system. And what does that mean for that individual? And I would just add, you touched on the essential jobs. You think about somebody who's working an essential job for $15 an hour, who needs to get on a bus, and for them to actually take the time off to go get a test. I mean, that's a big deal for them and their family. And so how do we reach those individuals where they are and really create a safe environment for testing for them? And I think that there have been some successes here, as well as in other locations where it's really around reaching out to those individuals, whether it's on a farm, in a hotel, or elsewhere.
Yeah, and I hope that our study in many ways, sort of encourages other places to look at they're testing the same way. I mean, looking at it by language, or if you have place of birth in your, electronic health record, just to look at it in those ways, because I think it will be illuminating, and may reveal gaps that weren't appreciated before. I think you were mentioning historically how we've seen this play out. I mean, there's a lot of good literature how the 2009 H1N1 pandemic revealed these disparities in racial and ethnic minorities. And when you actually drill down, we didn't get a chance to drill down to what might be underlying some of this, but social determinants of health were definitely at play. Like they were coming from low-income neighborhoods, or they looked at education level, high school or lower. And it was interesting how those things contributed greatly, and to the point where clinical risk factors accounted for maybe 39%, but it didn't explain it all. So I think that's important to dig deeper and look at some of these things that we're not, we're used to looking at race and ethnicity, but I think it's interesting to look at other aspects of how people identify.
Yep, absolutely. All right. Well, that brings us about the end of the session. Any other final points you want to get in about the study or the topic in general?
Herbie, you had last thoughts.
No, I don't think that there's anything specific. As Nina mentioned, there's traditionally kind of this idea of focusing on race and ethnicity, and there's a lot more to this story. And I think that additional studies that are done elsewhere that expand beyond kind of traditional academic medical centers or county health centers is really important.
Absolutely. And, one of the things that we're all learning now is that, it's not just about individual health, but everyone's health in an infectious pandemic affects us all. So thank you so much for this important work. Thank you for joining us today. And of course, if you're following along, you can get this paper free and open access at jamanetworkopen.com. We have new papers coming out every weekday at 10 a.m. And join us again next week on Tuesday at 3 p.m. Central Time for the next episode of JNO Live. And of course, take care and stay safe. Thanks again for coming.
Thank you.